Farghal.
Thank you very much, Professor Naema, for the presentation. It's my honor and a great pleasure. I try to share some insights we gained in the last years. I have been running independently very dedicated vertigo clinics for the last 20 years. And I witnessed personally the evolution of the vestibular testing. I got my basic training, and I'm honored to get it at Ain Shams University, Cairo, Egypt. And that was my basic training in the audiovestibular medicine. But over the years, I have been catching all the development and the evolution. And I witnessed personally the evaluation of vestibular assessment. Clinicians nowadays, they are fortunate because we have more knowledge, better understanding of the pathophysiology of the vestibular system. We have guidelines, especially the Barani Society guidelines and the consensus documents. We have tools. We have video head impulse testing. We have the ocular VIM. We have the CVIM. We have a lot of innovations and technologies which it appears in the last 10 years. So we are the fortunate generation of vestibular professionals. So I will share you in our expertise at King Abdulaziz Medical City, which is a tertiary care hospital, and we have a dedicated children hospital, and we have the main hospital, and we have a lot of referrals, and we have ENT residency training programs, and medical or health specialties universities. So we have one of the advantages in our clinics that we have a rapid access vertigo clinics. We can go direct referrals directly from the emergency room or second day, so it's common in our practice to see the patient during the acute stage. We do video nystagmography, we do video head impulse testing, we have 3 systems of video impulse testing. We have the VIM, ocular, and CVIM. We have a huge team of we call it the DISY team. We have ENT, we have myself, we have many audiologists, trained audiologists. We have a dedicated vestibular physical therapist within our team. So we provide a full package. And we have a good collaboration with the other departments, especially neurology department. And we are developing a migraine specialized test battery. One of the points I want to say here is that the available guidelines is really not adequate, and many cases of migraine or vestibular migraine being missed just because they don't fulfill the criteria. That's why there is no wonder more research is coming. And I just last month, I think I reviewed one paper for Frontiers about adding the motion sickness, the history of motion sickness as a very strong indicator and the diagnostic landmark for vestibular migraine. And we have been using this this parameter for many years in our clinic. And there is also growing literature to build some clinical signs of vestibular migraine, like the HIPAA sign by the Italian group, Professor Cassiani. So if you see that HIPAA sign, and we are working currently to make some quantification when it's significant. So HIPAA sign, some patterns of skull vibration used, vertical nystagmus, some motion sensitivity, some microsaccades in the video head impulse. So more, we are gaining more subtle or more minor signs to help in the diagnosis. Skull vibration test. We have been using skull vibration for many years, and it's a wonderful test. I highly recommend. You don't need to buy new equipment. You only buy a good vibrator. And it's very sensitive. And from my expertise, I can tell you, this is the most sensitive vestibular test. Most of the symptomatic patient, they really show some pattern of nystagmus. We observed some patterns like upbeating nystagmus and migraine. You get nystagmus on putting vibration on the right mastoid, on the left mastoid. In the third window syndrome, it will show the nystagmus. In superior canal dehiscence, in unilateral deficit, it will show the nystagmus. In central conditions can give you vertical nystagmus. You have to avoid using it in patient with retinal detachment or intraocular lenses. But it's a wonderful test and doesn't need any expensive equipment. So you just add it to your VNG. Hyperventilation test, it's a wonderful test. There is good work, good research about it. It can tell you if it's due to vascular issues or due to demyelination. It's the mostly important or the most important diagnostic test for cases like vestibular paroxysmia due to vascular compression loops or other causes. So it also shows in central conditions, it can give you some vertical nystagmus. So these tests are really very informative, and it gives valuable information. Bow and lean test, as Professor Nori he mentioned, it's very good test, especially you have a wheelchaired patients with nausea, vomiting, with limited mobility. So we tend routinely to test those patients in the upright position in the wheelchair. And if we decided to do repositioning, it shorten the procedures and it just go to the point. So in very nauseating patients and in patient on wheelchairs, upright examination for BBV is very good strategy. Minimal stimulus strategy for BBV, that's what I just mentioned. Subjective virtual verticality with the bucket test, just in Saudi Arabia, it costs 10 riyals, and our teams, they build the bucket test, and we do it routinely. Despite we have also some computerized system, but subjective virtual verticality is also a good test, especially in patients who experience tilting, sense of tilting of the head. Dizzy team, that's what we are happy to have in our clinic, that we have a multidisciplinary team. We have many people, many professionals working at the same patient at the same time. That's why we can handle a huge number of patients. So this is a very good model of practice, and we can see really huge number, and you can provide a very good service. And we also acquired some physical therapists. We train them so they become specialized in vestibular rehabilitation. They work within our clinics. And also we have virtual reality and posturography-based vestibular rehabilitation therapy, which is also, it helps in many conditions like motion sickness, visual motion sensitivity, visual dependence, agoraphobia, and like this. So, in the contemporary practice, we are fortunate because we have evidence-based protocols. And for history taking, we have the titrate, which is timing, trigger, and targeted eye examination by Newman Tucker and Johnson Idlo. So it's very good protocol, especially in acute vertigo. So stoned also by Floris Voits from Belgium. It's very nice. So it's for sense or for the symptoms and the duration, and you can Google it. It's authored by Floris Voits, associated otological symptoms, associated neurological symptoms. So it's a good frame or a good protocol to use, because it brings you to the point, to the diagnosis. And for titrate approach, it's wonderful. It's the most successful and most beneficial history-taking approach, because in 3 minutes you can get really to the point with narrow differential diagnosis. So you have acute prolonged spontaneous vertigo, it's either stroke or neuritis. You have episodic spontaneous vestibular disorder, so it's either migraine or Meniere or transient ischemic attacks. You have triggered episodic vestibular symptoms like BBV, so it's easy to categorize, and you narrow the differential diagnosis. I talked about the extended checklist for the migraine in the history taking. Also family history is a good point in taking assessment for migraine. Disco hat is also a protocol published by Herman and Raymond. It's intended to be used for patients with bilateral vestibulopathy, especially they do work with the vestibular implants. So that's available for everyone. You can Google and can use and implement it to your clinic. One of the really important concepts in the best practice of vestibular, in my humble point of view, you have to look for medical diagnosis, physiological diagnosis, and functional diagnosis. Because it's common, you have all your physiological and video nystagmography, VHAT, VIMB, all this is normal, but still the patient symptomatic. So medical diagnosis and physiological diagnosis, which it means instrumental, and functional diagnosis about their function. So that's very important to address these three aspects, so you don't miss any case, and you have a better outcome from your patients. Because if you did a VNG, V head vimp, and it's normal, told the patient you have nothing, but the patient has triple PD, for example, and he's suffering. So that's counterproductive and creates more stress and more problems to your patient. So this is the golden rule in our clinic. Before discharge of any patient, we have to get a medical diagnosis by a physician. We have to do physiological assessment with the vestibular test batteries, and we have to do functional diagnosis with the functional tests or by the Dizziness Handicap Inventory or other functional assessment tools. I want to refer to one some work we did, which we created. We have in audiology, we have very nice the grading for hearing loss, normal hearing, mild, moderate, severe, and profound, but for vestibular we don't have. And being a great advocate for video head impulse testing, really, we created the VR gain scale based on the video head impulse test, and we could, based on the literature view and our own expertise, we could bring this VR loss grading scale. So we have mild loss, we have moderate loss, we have severe loss, and we have profound loss, especially in the era of vestibular implantation. So it's actually, this is, I think, needed. We published it in Frontiers in 2022, and we use it, we apply it in our patient and give really a good insight, because the pathology of different conditions present with a different degree of VR gain loss. And always now we tend to classify it into end organ damage. We don't think a lot it's viral, it's vascular, it's ototoxicity or something. Now this is our own clinic, we call it end organ loss. So always end organ loss present with more severe VR gain loss. But in central conditions or other conditions that's like migraine or something, always tend to be of mild degree. And we put the 0.2 as the profound loss. This is, it happened to be in agreement with the work done by Michel Lacour, that always, if you have your patient with VR gain less than 0.2, that always they have poor outcome with vestibular rehabilitation. And now this week we are acquiring the balance belt for cases of bilateral vestibular loss, and we are willing to apply this scale for these cases. This is the Arabic version of vestibular disorder activities of daily living scales in common episodic vestibular disorders during and in between the attacks, a cross-sectional study that's done in our department and published in the Egyptian Journal of Otolaryngology. And our conclusion was always the attacks of Meniere's disease is the worst. Really, they need a sick leave during the activity of the disease. I wanted to refer you to this also great work by Herman Kingma and Raymond von de Berg from Netherlands, history taking in non-acute vestibular symptoms, a 4-step approach. That's a very good article, and I highly recommend it. That's really give you a good insight for history taking from your patients. So what we do when the patient come to our clinic, first we look to his walking way, ability to stand and walk, his gait. We look for tremors, head tilt, sweating, his speech, if he can speak or has a slurred speech, or aphonia or dysphonia. We look if he's nauseating, vomiting, carrying a vomiting bag, there is any facial asymmetry. This is just looking to the patient coming to your office. Then we look for any congenital or visual nystagmus. Ocular motility, we tested the ocular motility, and I can tell you that even our non-physician audiologist team now, over the years, they can easily pick 6 nerve palsy, or they pick something like 3rd nerve palsy. They just, with experienced people, it's easy to learn. Horizontal and vertical gaze testing for internuclear ophthalmoplegia, smooth pursuit. So usually some people pay more attention for the gain in smooth pursuit. Actually, the saccadic smooth pursuit is more significant, and it points more to like cerebellar or central pathology than the gain, because the gain can be affected by attention, visual acuity, the calibration, and the distance. But this saccadic pattern, no, cannot be generated by this condition, so it's more specific sign. Horizontal random saccade, again to check for internuclear ophthalmoplegia, vertical pursuit and saccade if progressive supranuclear palsy is suspected, clinical head impulse test, modified clinical test of sensory interaction balance, just you need the form and you can do that. It's very good test, and it do 90% of the function of the static posturography. It costs nothing. Finger to nose and rapid alternate head movements, and other tests depending on the history. Then in the VNG examination, actually the traditional way of teaching the video nystagmography is completely different than what we serve in our clinic. So we look for different signs, like for example, we look for ansechoria. It's unequal pupil size. That's very common with migraine, and sometimes if you have Horner syndrome, now we look for the Hippas sign as a sign for migraine, but we find that it's common to most of the people we examine, they do have hip sign, so we are working to do some quantification about its significance. We look for spontaneous nystagmus, horizontal, upbeating, torsional, or downbeating. Then we test for gaze-evoked nystagmus, exaggerated endpoint nystagmus, that's also common finding in migraine patients, especially with vision denied. Side pocket nystagmus, convergent spasms, that's also important sign. Exceptionally, it's due to Bernard's syndrome. It's a central condition, but it's common with anxiety. Square jerky waves, ocular flutter, saccadic oscillations, and opsoclonus, monoocular nystagmus, especially if there is like a visual, unilateral visual impairment, and combinations. That's common because in many patients we find many patterns of eye movement in the same patients, and it's not hard to quantify and separate and interpret. Provocative test in video nystagmography, that's very important. It's much more important just doing the caloric test or seeking, and it's more informative than just doing the oculomotor testing, like head shaking, hyperventilation test, as I mentioned before, skull vibration test I mentioned early in this presentation, and in my personal experience, the most sensitive vestibular test, because majority of the symptomatic patients, they show some sort of skull vibration induced nystagmus, but you have to find the proper vibrator, and you use your video nystagmography system or video goggles. Dexual bike, McClure Bagnini test, bow and lean test, head hanging, fistula test, Valsalva test, and sometimes we do for loud sound induced vertigo. The time is very limited, so that's a case of Valsalva maneuver. In a case of superior canal dehiscence, you see, with just the forced Valsalva, he has a downbeating torsional, and after he stopped, it got reversed. That was a very definite superior canal dehiscence syndrome, and we referred that's the only patient I recommended surgery for him. And that is the OVIMP. The OVIMP is very specific, and you can see in this case, it's very clear that it is the affected side, which is the left. It's very, very low threshold and large amplitude. It's even more diagnostic here, the OVIMP, than the CVIMP. BBV, we have a wonderful instruction course by Professor Nori, but just I share with you some insight from our clinic. So BBV or variants, including canal jams, they do exist. Anterior canal do exist. Apogeotropic posterior canal.
1 minute, Professor Clara.
Okay. So how many minutes? 1 minute? No, give me 2-3 minutes additional. I am your student, Dr. Naema. So anyhow, one message for BBV. There is last week one article it came that is reporting correlation between the sleeping side and the BBV, and this is we have been using in our clinics for many years, and we do believe it's good. When you are confused where is the affected side, especially in the horizontal canal, just ask the patient where is which side you sleep on it. Okay, I just try to get Sorry, it's always have problem in the time. So video head impulse is really a core vestibular testing. It gives a great insight. It gives a very fast information. I'll just share. Yeah. I take 30 minutes? No, Doctora, I started late. I don't think it's 30 minutes. Please restart. I didn't take 30 minutes. We started late, Doctora. If the audience want me to continue, I'll do. Doctora Nego. Because really, I'm losing the... Okay. So just I share with you some clinical cases, because this is... Okay, so this is one case. This is a 43 years old female presented by acute vertigo for 24 hours durations, showed right beating spontaneous nystagmus, and I tested with the 3 head impulse systems. As you see, all of them, they showed that she has left vestibular hypofunction. So again, another case, this is a bilateral vestibular areflexia tested by 2 different video head impulse systems, and it gives the same results. So this is important case, because this is tell you what is the contemporary vestibular practice, how it looks like. So 76 years old, the patient, poor balance 14 years, get worse in the last 6 months, mild diabetes mellitus, right eye ptosis, bilateral severe sloping sensory neural hearing loss, tried a lot of medications and a lot of repositioning exercises for dizziness, but no benefit. He came to our clinic. Immediately we do the video head impulse, and you see, sick patient, 14 years, he has bilateral vestibular areflexia, not loss, areflexia, that's profound loss, and for the 10 years, and he was not diagnosed, and we could diagnose in 5 minutes. But this is the luxury of the contemporary vestibular practice. I'll just choose one case, and then I will end. So 16 years old, adolescent, frequently recurrent vertigo attacks of 1 year duration. We did the video head impulse testing. It was normal in all the 6 canals. CVIM, it was normal. OVIM, it was affected or absent in the left side. He has left moderate sensory neural hearing loss. We did the ECOG testing, but I flipped the traces. He has increased SCB-AB ratio in both sides. We did the mini eyes caloric test, which I love a lot, the mini eyes caloric test. He showed left ear areflexia, right ear normal response, and that brings another point, that is to share with you what are the current methods to prove the presence of endolymphatic hydrops, which is a cardinal feature of Meniere's disease. There is a new hydration test using furosemide and methylprednisolone, the Italian group, and I was one of the authors of this work. So it depends mainly on the furosemide. Then you do audiometry, you do ECOG, and you check if there is a significant improvement after like 45 or 1 hour after the injection. The discrepancy between caloric testing and the video head impulse testing is well reported, and it's considered also, it's common in Meniere's disease, and it also can be found in vestibular schwannoma, and sometimes in enlarged vestibular aqueduct. The Japanese people also, they publish furosemide loaded VIMP. So if you have absent VIMP, you give furosemide, then you test for VIMP. If it appears, that's also indicator of endolymphatic hydrops. ECOG rarefaction versus condensation, there will be significant difference. ECOG area ratio, I don't believe it has any value. I criticize the concept behind it. So still, I think the SCB-AB ratio is more, it gives more valid information. The area ratio just make everyone Meniere's disease or endolymphatic hydrops. And just, I have many concerns about its seminal publication. 3 Tesla MRI, this is now, it's become a reality with delayed gadolinium, and many colleagues in different parts of the world, they are working on it. So unfortunately, more than 65% of what I want to share with you, the time does not allow, but this is in brief the message I wanted to share. The vestibular field is very dynamic and continuously new innovations are being introduced into the field. My vestibular ideology is continuously evolving since I have been into this field 24 years ago. The way we do currently practice vestibulology gives us immense pleasure by helping thousands of patients every year and by being able to solve complex or vague clinical cases on timely basis. Thank you very much.